much for coming. My name's Jane Anderson and I co-chair the London Fast Track Cities London Leadership Group, and I've been chairing the Task and Finish group for this piece of work. So I'm absolutely delighted to chair this session, but the vast majority of the information is going to come from other members of the Task and Finish group and from you as participants, who we hope will have a really robust and good discussion about what we're doing. A couple of housekeeping points. First of all, can you keep yourself on mute with your camera off while we're talking, just to try and save a bit of bandwidth? Please put your comments into the chat as we go along, and Gemma is going to be moderating the Q&A session and will be collecting things from the chat. So two things: please put things in, otherwise Gemma's going to have to think hard about what to talk about, and equally, that's the way to get our attention, is to put things in there. The session is being recorded, so please, if you're not happy with that, either leave or turn your camera off or let us know. What we're doing, because it's recorded, we're due to finish at 6:20, but if we are tight for time, we can carry on for a little bit longer, and we'll make sure we pick up any other conversation that goes on so that people can catch up with what's said later. And importantly, we can catch what people are saying if people want to say more. The links to the SurveyMonkey, which allow you to give your feedback, you should all have had those, and I think Eleanor and Jess are making absolutely sure that you've got those. But the real purpose for today is to get your sense of your feedback, a sense of where we're going, and to hear your comments on the work that we've done so far. So let me kick off. We've got speakers Jackie Lindo, Mel and Rebecca from the community, and Laura. I think both Laura and Nikki are here from the Clinical Forum, but I'm going to just try and set the scene to start us off so that you get a sense of where this report's come from and how we got to here. So Eleanor, I've got a few slides. I don't know if you could try, and this is the moment of truth in any meeting, just to see if we've got everything there. Yes, we have. Fantastic. Okay, so we have produced a report, Evolving HIV Care in London, which has been written on our behalf by Ruth Lowbury, who I think is probably known to many of you as the ex-chief executive of Medfash, who has a very strong background in HIV, sexual health, and in policy. And so we've been very lucky to get Ruth out of retirement to work with us on this. So the authorship of this is from Ruth, and she has been listening, researching, and writing up into the document that you've had an opportunity to see. If I could have the next slide, please. Fingers crossed. Does that work, Eleanor? Yes, okay. So I was going to give you a little bit of an idea of how we got to here. So I've done it as a bit of a timeline, but really I think things started in February 2020. I would say that's the starting point, when NHS England London initiated the discussion about the future of HIV care in our city. And Laura and Nikki, myself, Kevin Fenton, John Sawley from BASH, Anisha Noonan were convened by Simon Barton in NHS England to really say, look, things are changing in the landscape in London. The epidemiology of HIV is changing. We need to think about what services are going to look like in order to ensure the best outcomes for Londoners living with and affected by HIV. So and I think, Jackie, I remember us being in that room and you saying, oh, there's somebody who's not very well, who's come back from a skiing trip in northern Italy. And so although we had that preliminary conversation, we all know what happened next. And that was that COVID arrived and everybody was busy with wave one. So really, the opportunity to start this piece of work began in the summer of 2020. And that's because not only was that initial flag from Simon Barton, you know, what do we need to do next? But it became imperative because there was so much recovery planning going on across health and social care, and the formation of the integrated care systems meant that the infrastructure for commissioning was also changing. So there was a real opportunity at this point to really try and make sure that we could influence that change and make sure that the system understood what needed to happen to get the best outcomes going forward. So we agreed that we could use the Fast Track Cities infrastructure to support a whole systems approach, because the whole Fast Track Cities, we have everybody represented at that table. So we managed to secure budget, which was signed off by the leadership group. The plans were presented to the wider health system, and the London Clinical Advisory Group is really, I suppose, the place where this sits for the whole of London, which has kind of oversight of what's going on in our city. Ruth was commissioned, the Task and Finish group was established, the Community Advisory Group was established, and I think Mel and Rebecca will say a little bit more, but one thing that I just want to say, which I think was really important, was that we have managed to ensure that we have budget to ensure we have a remunerated Community Advisory Group, because this has been work and everybody has done work that deserves appropriate reward. And the HIV Clinical Forum, which was already in place, was really well placed to deliver the clinical leadership to take us forward. So we got it all set up, and then by winter 2020 and through to now, we've been doing the work, intermittently interrupted by wave 2, intermittently interrupted by a whole lot of other things. But overall, we have had the most amazing engagement from the Task and Finish group. We've had fortnightly meetings, pretty much, workshopping key issues. The Community Advisory Group have been meeting regularly with two-way communication. The HIV Forum, Nikki and Laura have been convening and engaging, and the other members have also been working to make sure the clinical body is engaged. And the report has been drafted, reviewed, redrafted, read again, redrafted, and the document you have in front of you now is really us testing where we've got to now for you to see the direction of travel. And of course, what we'd like to do is take this forward into autumn and launch a finished document, go live, disseminate, support, and of course, try and make sure that things are implemented. Next slide, please, Eleanor. There's a brief diagram of kind of how this all works. And that is, in the middle, you've got the Task and Finish group in orange, with the feed-in coming from the Clinical Forum on the left in grey, and the Community Advisory Board from the right in yellow, but all joined up, reporting into the London Fast Track Cities Leadership Group for accountability. And the health and care system overall is where we end up reporting to in terms of the governance. And the final slide, I've listed, I hope, everybody who's been involved in the Task and Finish group. And I hope you can see from this list that we've had major input from the community, the Clinical Forum, specialist nursing, the voluntary sector, primary care, Public Health England, NHS England, IAPAC through me in the international arena, the Healthy London Partnership, without whom we could not have done this and whose support has been absolutely pivotal, and Ruth, who's done so much of the work. Now, one constituency that is not in this list is London Councils, and that was a decision that they took at the beginning. They have asked to be kept informed, and they are being informed regularly through the London Leadership Group, and they have been commenting as we've gone through. But this was the way that they wanted us to take this piece of work forward. So they are well cited, even though they're not on that list. So that's sort of where we've got to now. That's how we got to here. That's how the document you've got in front of you has been arrived at. And I'm now going to hand over to Jackie Lindo, who is Public Health England London's advisor to NHS England, and who leads that portfolio for HIV, to tell us a little bit more about what's actually in the report from her perspective. So Jackie, can I hand over to you now, please?
Yeah, certainly, Jane. Thank you very much for the introduction. And it's lovely to see so many people, if only virtually. on this meeting. So I'm down on the agenda to speak about key principles. When I started to make some notes about this, I had quite a long list. Fortunately for you this evening, I've whittled it down to 3 key principles. So in London, by 2030, we want to achieve 0 new HIV infections, 0 preventable HIV-related deaths, 0 HIV stigma. Why? We want London to be the healthiest city in the world, global city in the world, and therefore we want the best health and quality of life for people living with HIV. So in terms of key principles, what I want to talk to you about this evening are essentially 3. So leadership, subsidiarity, and equity. So let's take the first. So leadership, my simple definition of leadership is the FED approach. So a leader as an individual or a group will set out the future vision, will then engage with the relevant sectors, relevant individuals. They know who to speak with, and then they'll deliver on that vision. So I suppose what I'm saying here is that in order to deliver for Londoners, we need leaders who will listen, encourage innovation, leaders who think outside the box. And of course, with that comes accountability. So you do what you say you're going to do. So an important aspect of leadership is, as I said, is setting out the vision for a system. This needs to be a shared vision because constituent partners will have their own vision, their own goals, their own objectives that they need to meet. But without a shared vision, a shared purpose, a shared set of values, we as a system will fail to provide care and support will fail to provide care and support that feels seamless to Londoners affected by HIV. Apologies, I've got a little child screaming out the window. Fortunately, we will not be starting from scratch. As Jane has already mentioned, we have quite a good leadership infrastructure within London, including the FTCI Leadership Group, our HIV provider network, clinical networks, the Association of Directors of Public Health, and Community Advisory Group, and so on. So in taking forward the recommendations of the report, we'll need to realign our leadership and governance structures in light of the emerging integrated care systems and integrated care partnerships. The second principle I wanted to discuss was subsidiarity. And this will be a key element of this new leadership structure that we require within London. Because what we need to do is to delegate the decision making as close to communities as possible. So there will be things that it makes sense to do at different levels. So for example, there are things that it makes sense to do once. So for example, that would be setting national clinical standards, such as a service specification, which is set by NHS England for HIV care, healthcare. We've got NICE guidance. It makes sense to be using what's nationally produced by NICE, and we've got BEVA who set clinical service standards. But at a London level, we may want to be thinking about models of care for London to meet the needs of Londoners. We may want to be thinking about a consistent method for, say, risk stratification, or we may want to have a London-wide approach as we do with our campaigns, Do It for London campaigns. We may want to develop approaches across prevention and approaches that help to reduce stigma. And then there are other decisions that would be best made at sub-regional levels. So at integrated care system level, we want to respond to the distribution of the burden of risk, the burden of disease within the ICS geography. So we may want to develop joint integrated primary, secondary care clinics in the community. And beneath that level, we may be thinking about primary care networks. We may want to develop a lead practice for HIV and have shared care arrangements. In terms of equity, this speaks to the heart of public health and myself professionally. It's about fairness. So for Londoners, we want equitable access to health and care services. We know that due to current commissioning arrangements, there's unwarranted variation in service provision. So there's unwarranted variation in access to, say, early diagnosis because of differing levels of testing provision across the capital. in terms of access to community-based HIV support to support individuals living with issues around isolation, loneliness, poverty, poor housing. We know there's unwarranted variation in access to psychological support, in access to pre-exposure prophylaxis. We also want equitable outcomes for Londoners. So we know that there is unwarranted variation in service user experience. For some individuals, they will say they've had seamless care, all their needs have been met, and therefore they feel the service is working well. On the other hand, this isn't the same experience for some of our Londoners. In terms of health outcomes, including a good quality of life, viral suppression, and so on, we know we've exceeded the UNAIDS targets of 90-90-90, but beneath that, we know that there is not consistently achieved for all population groups, and we know these can vary by place, ethnicity, gender, socioeconomic factors. So in relation to equity, I would argue that population health management provides the opportunity to be able to risk stratify our population and allow targeting resources, the right resources to the right level of need in the right place. So for example, for those at risk of acquiring HIV, we make sure we have Do It for London campaign that reaches all parts of London. We could also ensure that there is even access to pre-exposure prophylaxis, because currently most individuals who require it have to access it through a genitourinary medicine clinic. For those who are newly diagnosed, in addition to effective antiretroviral therapy, they will need support to deal with the emotional and psychological burden that comes with such a diagnosis. And this will help those newly diagnosed to engage with services and to remain in care. For those people with what we could classify as stable disease, so they are in treatment, they're virally suppressed, we want to support them to remain engaged with care and to live well. So we'll need to make sure there are support services there. And then those within increased risk of, say, complex disease, in addition to, support that you would provide for those with stable disease, you may need additional interventions to optimize the management of serious mental illness or the management of renal impairment, for example. So to conclude, in London, we want to achieve by 2030, 0 new HIV infections, 0 preventable HIV-related deaths, 0 HIV stigma, and we want the best health and quality of life for people living with HIV. So if we bear in mind the key principles around leadership, subsidiarity, and equity, when we're taking forward the recommendations within the report, I think we'll get there. Thank you. I'll hand over to Mel and Rebecca.
Thank you, Jackie. I've been asked to talk about why the report matters to the community. And having discussed it with the community, we've come down to 3 main points. First one being, we know what we need as a community. The report recommends a person-centered approach. So we as a community need to be at the center to share our expertise on what works when it comes to prevention, stigma, when we're newly diagnosed, as we age, our experiences with comorbidities, as women, as gay men, as trans women, and other minoritized groups. Also as people embedded within the intersectionalities that impact our lives, not just as people living with HIV, but as people living in London. Second point is we are effective. As people living with HIV, we already live a cost-effective lives, and we want services that work and make the best use of the resources that are available. Therefore, working with a community, we feel, is a cost-effective way of doing so. And finally, I think one of the things that we also thought about is the report matters because we have lost so many services through fragmentation, austerity, through the postcode lottery of who provides what services and to whom. But this report highlights what we've discussed as a community and is possible if we have the ear of the ICSs to work together to make this achievable. I'll hand over to you, Mel, for the next point.
Thank you. So I'm going to talk about how we were involved, and we were involved a lot as a community. Fast Track Cities Initiative, I think, has a good reputation on asking community what's important and what's needed. And so when the idea, as Jane said, of doing this report, I think community were at the forefront. So they used their links to gather representatives, advocates that they knew to form a community advisory group. And that community advisory group was never going to be tokenistic. It was always going to be quite vocal, and it started with the idea that it needed a chair. So that's when I was elected and came in, and they wanted a chair who was living with HIV. So it was, they really had this drive to begin with about what was going to work and what needed to be done to do this. So it's been a real privilege and inspiration to guide this group and to report back, and it really shows how community voices can work together. So our input has been valued throughout, intellectually and financially, and disruptive voices have been listened to, which is important, because when you've got if you've got a group that just agree with you, what's the point? So we have disruptive voices, and in that we get a whole spectrum of ideas, and we can really discuss what's important. So initially we were presented with the Beaver Standards of Care and a timetable, but many representatives and advocates on the group, which were a diverse representation, I have to say that as well. And even if there were some gaps, we were able to reach out to make sure that everyone's opinions were heard or reflected. So we started with kind of throwing out the Beaver Standards of Care to say that, you know, we are very frustrated as a community to be asked for quotes, asked for recommendations, and we work hard putting reports together, but then they just end up on a dusty shelf, you know, and they're there for reference, but they're not actually action. So we wanted to move away from that frustration and just really make something that could be action, that could be effective, that we could offer the integrated care services to work for us. So we created our own agenda, we looked at case studies, so it was actually grounded in our reality of our experience in London. And we met for 8 workshops with 4 themes, which was the evolving shape of the HIV epidemic, integration and coordination of care, complex care, and modernisation of services. And with each topic, we had 2 case studies where sometimes things worked well and sometimes they didn't. And we discussed these along with the themes, and really there were some recurring issues that came up. Basically, the disparity of care in London, as has already been mentioned, but this really did come up. Stigma, mental health, and that's the whole spectrum of mental health. So, you know, low level to really complex care. And then the value of peer support. So that's also the spectrum of peer support, not just peer mentoring in clinics, but the value of group peer facilitation in groups, meeting as a group, meeting in your community. Really the importance of peer support being that safe space with a shared experience. So the case studies, as I said, it really depended where you access care to what you were able to receive. So some clinics had fantastic medical checks but lacked psychosocial support. Others had community involvement to link care, but a person in that case study had experienced a late diagnosis. So that's where early testing would have been really helpful in their quality of life. Others, HIV was actually the least of their problems, and there was a need to address trauma, housing, immigration, food, you know, so there really is a very different. Everyone can have a very different experience in London, and that can be with their GPs, who can be real champions, or can be very stigmatizing. So it's really important for the ICSs to understand that there's a whole, it's not a one size fits all. There's a lot of different things that go on, and there are some excellent services and there are some not so desirable services. So we came up with the recommendations, and I and Rebecca shared with the Task and Finish group and the writing group. And as Jane has already said, it went through various stages, various drafts. And I'd just like to hold my hand up to Ruth, who actually, the writer, she attended all our community advisory meetings, not as someone, wanting to get involved, but just really listening. And I really feel that she did hear us, because even some points she reflected back that when I looked at my notes, she really had taken on board what we'd said. So I think that says why this report has a lot of strength to it, because it's managed to condense all the elements and all the influences into a really rich source of information that can be taken forward. So we have been involved as in the community from the start, and we are here involved in this webinar, and we are also going to be involved in the future. So we really want to continue to make London a world leader in preventing HIV and caring for us holistically. Back to Rebecca.
Thanks, Mel. I think that's a really good sort of link into what I'm going to talk about now, is how we want to or could be involved in the future. And again, we've whittled it down to a few points. The first one being, we, the community, want to continue to be as involved as we have been in the Fast Track City Evolving Care Community Advisory Group. The process that we followed is a very good example, as we were embedded in the process right from the beginning, and not just tokenistically, as is usually the case when we're asked for quotes at the end. Fast Track Cities initiative recognized the community needed to be involved, and they made sure it was done. So we felt valued for our expertise, our innovation, and our input. Second point is, we are here. There's an infrastructure set up already, and there are opportunities to continue to evolve this. So linking up with Fast Track Cities to explore the present infrastructure and how this can be developed further and replicated with the community, being involved from the beginning, would be a good way to go forward, with unique opportunity which aligns with the ICS focus currently to start reshaping the health service at a time following a pandemic. So it's really important to make good strategic choices. Next point is to be strategic and put people living with HIV. Sorry, I've got ice cream van in the background. So I'll try and raise my voice. To be strategic and put people living with HIV at the forefront. And as we've said before, we would like to be involved and continue to be involved. And then we would like to be able to move away from this top-down way of thinking, having different conversations and being curious. We know how it feels like to not have money. We know what it feels like to have insecure housing, or when your immigration status is uncertain and you're not allowed to work and have no access to funds. And so, we already live below the poverty line, so we're best equipped to help inform what works and what doesn't, and what is most effective and what isn't. And on that note, I am going to switch off my sound. Thanks.
And go out and get an ice cream. So the last section for us in the community was and how we can also support you. So you can support us as an ICS by valuing us, by listening to our expertise and giving us a seat at the table to share what's happening in our community, in our neighbourhood and in our place, and really what has worked and what will work. So we need, as a community, to connect locally, but also pan-London. And we need to understand that people living with HIV access services in London, but not always in the borough that they live and work. So this is really important, that we don't have this disparity of services, and that we can link across the trusts, the sectors, the STPs, the ICSs, so that we can link where we have our centres of clinical excellence and we have our amazing grassroots community support and prevention. We need to think how we can link them together and also include housing, crisis support, mental health, drug and alcohol services, but also employment opportunities, social prescribing, art, culture, all the things that we need to live well so that they're accessible across the whole city. Because London is a place where people move around, and that is its dynamism and its potential. And ICSs can achieve services for people living with HIV, which can be an exemplar for people living with other long-term health conditions, for other Londoners. If you support us, we can support you. We don't know, as we've said, what the future is, how our health service will look like in 2 years, in 2025, in 2030. But we do know that we've found ways to come together, we found innovative ways, and we've also highlighted, as Jackie said, the inequalities and the failures of the current structures of power. So we found this great new way for community to be involved, not as passive participants or isolated patient reps, but as linked, supported communicators who are sharing and disseminating that information. So we need to stop being blinkered in our thinking, and we need to open our eyes wide to see who is there and to be able to engage with all the different populations. Because if you do not engage with populations, how do you know what the best way to support them is? As an ICS, how are you going to sort out the problems? And how are you going to replicate their successes? So on that note, I'm also donning my U equals U t-shirt, and I'd just like to highlight, it's going to be in the report as well, undetectable equals untransmittable. But I think this is a really good example of how community voice is very powerful. This was a community initiative. We knew that this was an important message that would help people with improving lives, improving stigma. And now it's part of a major stigma campaigns. And so it highlights that we know what works, what is cost effective, and what is also effective in improving people's lives. So Fast Track Cities initiatives and the ICSs can support us by linking with us, by listening to us, as we as a community want to support you. We want to join the dots of the fragmented provision, and connecting together creates this dialogue and it supports action. Our lived experience is a powerful tool to improve existing services and identify new and better ways to meet people's needs. We have a real opportunity here for people living with HIV as a community to come together with local partners, London partners, and work differently to develop coordinated services focused on our needs, which ultimately benefits everyone in London and beyond. So let's link, let's talk, and let's listen to each other. Thank you. And I think now we're going to go on to Laura and Nikki.
So while we wait for Laura and Nikki to join, just a reminder that we have got a chat box. You can put questions in it. So any aspects of care that you feel we've not touched on enough, or you want some clarification, please do that.
Hello. Shall I start?
Yes, please. Yes.
The slide I submitted, I'm assuming you guys are going to share it.
Yes, 1 second.
Fabulous, thank you. So just to introduce myself, everyone, I'm Laura Waters. I'm a doctor in the Morton Market Centre in central London, and with my colleague and friend Nikki Mackie, I co-chair the London HIV Clinical Forum. So there's builds on the slide, so I'll just say next build for each time. So what is the London HIV Clinical Forum and what do we do? Next slide. So essentially, it's been in place for years, about 20 years, and the group provides HIV clinical leadership and expertise to NHS England. Next slide. And who we are, it's made up of the lead HIV clinician from every London centre. It includes specialist pharmacists, it includes community representatives, people living with HIV, and colleagues from NHS England and Public Health England. Next slide. And what we do is we meet at least quarterly to review care, plan quality improvements, monitor outcomes, and promote cost-effective prescribing. Next slide. Now, just to give you an example of some of our outputs, we produce regional prescribing algorithms. Now, thankfully, as of now, HIV drugs are procured nationally rather than regionally. So it used to be that each region, which is London, the South, Midlands and East and the North, each region went through their own kind of procurement processes for HIV drugs. And that meant each region had cost-based guidance, which was broadly similar, but there were some differences. But we historically produced guidance 2 iterations, and that has really supported huge amounts of savings across London in terms of what we spend. Next slide. And the other thing that we fostered was the mortality review. So this is an in-depth review of mortality cases across London, and that's yielded some really important lessons, has now been rolled out nationally so that we can learn from mortality and make sure we can try and reduce preventable deaths to 0. Next slide. So in terms of where we're going to go moving forwards, well, with, of course, the NHS white paper looming, then we really want to work to promote integration of primary, secondary and specialist care. And certainly looking at some of the comments in the chat, that's clearly going to need to be fairly individualised in terms of individual general practices, how many people with HIV they see, but of course being very mindful of what Mel has pointed out, that people in London may not necessarily live in London or may not live within the particular London region where they access care. Next slide. I can't see what this one says underneath the thing, but we want to, can anyone tell me what that box actually says? Support the move to national procurement. So this new process I've told you about, really the idea of national procurement is to make things more equitable across the country. But we want to make sure things are really clear, because we hear that people aren't necessarily interpreting the guidance in the same way. And we want to make sure that everybody's got access to the treatments that are best to them, and that these algorithms designed to support efficient use of our resources aren't a barrier to people being on the therapy that's most suitable to their needs. Next slide. And learning from this whole process, we've of course reflected on our own makeup, and the forum's kind of been something that's grown organically and evolved organically over the years. Of course, we've experienced COVID interruptions. There's been some interruptions in the support we get from NHS England, because of course NHS England's been through a number of changes as well. And that's really made us reflect on how this particular group is structured, who is represented on it. And I think we've realised we really need to get broader MDT representation, of course trying to engage with ICSs where we can, although of course being mindful that they're going to have an awful lot on their plates. So next slide and final build. So with and there's the map of the ICSs just behind there. Our goal is as an adjunct to all the work that we're hearing about today, is to evolve the London HIV Clinical Forum into a kind of clinical strategy group to provide some clinical detail to meet the aims that are described in this report. Of course, the clinical advice and expertise, helping where we can to coordinate, integrate care, to set and monitor some regional standards, because I think that's the key thing, is ensuring that this very significant change in how healthcare services are structured doesn't impact the overall fantastic outcomes that we enjoy. But of course, as Jackie well pointed out, there are inequities, and we want to be able to promote equitable care, promote the best outcomes, and also have the levers. We need real-time monitoring, but also effective levers to implement change where that is necessary. And finally, of course, it's not all about money, far from it, but we do see it as our duty to promote drug and care efficiencies wherever we can. And I think there'll be some really important lessons learned over COVID in terms of how much monitoring is done out of habit rather than need. What can we do about getting medications to people more efficiently? And where can we make savings to invest in making sure that care is as seamless as possible? So I shall finish there. If Nikki's got anything to add, and thank you very much.
Thanks, Laura. Sorry, I'm trying to get my camera on as well. No, I don't. In fact, as you know, I didn't think I was going to get to this meeting at all, and I have to actually leave in a few minutes. But no, I think you really summarised that in a very sort of clear, articulate way. And I mean, I hope that this will all, lead to lots of useful and pleasant discussion.
Thank you. Thanks very much. So that leads us into our Q&A session now. My name's Gemma Gilbert. I'm a Director of Transformation at Healthy London Partnership, and have the absolute honour of supporting the Fast Tracks Cities Initiative as the delivery arm of that programme. And I just want to say a big thank you to all of the speakers for putting across what we're trying to do here in such an articulate fashion. And I think you can really sort of sense and feel, if you're in this room, just what a high level of involvement there has been, and what strong community leadership we've had, and that has just been a wonderful experience for myself and for colleagues involved in this programme, and having done transformation for many years, just to see how deeply that's been brought forward in this work has been absolutely wonderful. So we're kind of coming on to the Q&A session now. Because this session is recorded, I have to ask people to kind of stay off camera and muted, but we did get a number of questions in advance, which was brilliant. And then I've picked up a few more things from the chat box, and I'm going to try and pull through kind of what I can for you. And then I'll invite the panel to come on screen. So if we have panel members in the room now, if they could just kind of put themselves on the screen. And together we'll be kind of fielding the questions that we've had. So I'll just give them a couple of minutes to join. Okay. Great. If I can see you, I remember who to field it to. Fantastic. And Mel, everybody wants your T-shirt. I think we're going to have to go into production and get a sponsor to help.
Yeah, you have to be good friends with Angelina. Even Rebecca's jealous because she hasn't got one yet. They're in limited supply.
Okay, my team are all WhatsApping me and saying we want Mel's T-shirt.
Yeah.
Okay, well, we have a few people from the panel on screen now, and I can remember who else we've got in the room. So the first thing I wanted to talk about with you and pick up, because it kind of came into the chat box very early on, and just a thank you to George for raising it, really. As you were talking, we talked a lot about long-term condition management, didn't we? And sort of those new emerging models of that we're seeing across the NHS. And we did a lot of thinking on that, didn't we? About how do we apply that to HIV care, and what's the right model? And there were some elements of that mentioned. And I'm thinking particularly about care planning and the importance of care planning. And I wondered if anyone on the panel would like to say a bit more about, why care planning is really important, and what it means as a tool in the box in the future, as something that we can kind of use. So let's think about what George said about, multiple long-term conditions, holistic care, care planning, and perhaps that sort of peer support role in that as well. I don't know if anyone on the panel would like to kind of kick off and talk about how does the Evolving HIV Care document help us start to address that? George, at the moment, George, we're just going to the panel to just get a response to that question.
Okay, I was going to put it a bit more simpler.
So, George, we're asking, because it's a recorded session, we're asking all of our participants to stay off camera and on mute, and we will try and field the number of questions that we have. Thank you. Thanks very much, George. It's really kind. Okay. Jane, I'm going to come to you and ask you to talk about how does Evolving...
Okay, good.
You there, Jane?
Okay. Yes, I'm here.
So how does this Evolving HIV Care document address this issue around, multiple long-term conditions, holistic care, thinking about care planning and those models of care?
Yeah, well, I think it's a really important issue, and actually it's quite interesting. So the last lot of changes to the health and social care landscape fragmented our ability to do this. And there is the theoretical benefit of the ICSs is that there will be a much more joined up approach and a much more person-centered approach. So I think that if we can ensure that what Mel and Rebecca have articulated, the absolute need for the complex bits of HIV to be joined up, and we have to go beyond the virus. So we have fabulous medication to suppress the virus, but we have to look after the people as whole people. And so it's how do we make sure those services are all aligned? And I think one thing which is really important is that at the moment, care coordination happens in so many different ways. Some clinics it happens in the HIV service, some places it happens in primary care, some places it happens in the voluntary sector. A lot of the time it doesn't happen at all. And there is no recognition that integrating and joining up different strands of care is work. So there's a kind of sense that it might just happen. But here we have an opportunity with the report. We've outlined, I think, the fact that there is so many different angles and things that overlap. There are so many intersectional approaches that actually, if we take a person-centered approach and the ICSs are able to take a person-centered, place-based approach, which is equitable, we may begin to join some of these dots up. And at the moment, I think the current system pushes us apart, if you like, and the new system has got the potential to bring things together. But we have to show them, I think, and I'm sorry to sound a bit patronizing, but I think we need to show people what that joining up looks like, because it's all very easy to say, oh, well, we want everything joined up. What does that mean? And it may mean different things for different people. It may mean different things in different places, but actually trying to demonstrate what joined up looks like is absolutely critically important so that that model is there.
Fantastic. Thank you, Jane. If any members of the panel want to come in as well, if you just raise your hand using the raising hand button, then I'll know that you want to say something too. That would be fantastic. Thank you. So I'm going to kind of move us on then to sort of another key question. Actually, Laura, I'm glad. Oh, Laura, did you want to respond on that one too before I move on?
Yeah, no. I think just to add, I mean, obviously it's going to be really complex. It's not a change that's suddenly going to happen overnight. You know, it's going to take time for this to bed in, and we've already heard that because of the understandable and enormous pressures on the system at the moment, that the specialised services that HIV sits in that have been managed nationally, which has been good in some ways, but it has created these sort of autonomous bubbles that don't necessarily mean that we're joining care up very well. But I think the timelines have been pushed back a bit. And I think in terms of like when the kind of commissioning and financial levers are going to be in place, it may not be quite as soon as we first thought. So I think 2023 is more realistic. But I guess the thing we have to think of is the fact it works both ways. And as Jane's pointed out, care coordination happens in different places. And I think the difficulty is obviously HIV services want to do as much as they possibly can, but I think we must recognise and come up with a strategy of how to manage the fact that by doing that, we are actually ourselves acting as a barrier to integrating with the rest of the system. And of course, we do it with the very best of intentions, but it's going to be tricky. It's going to take time, and of course, we also have to acknowledge that we're in an era of big backlogs in other healthcare sectors, and we don't get everything right, and we're far from perfect. But I do think we have thankfully managed to maintain safe HIV care throughout all of this, and we want to do everything we can to make sure that we promote and don't act as barriers towards integration.
Great, thank you. I'm going to pull two more kind of questions through. For some of these we've received before, as I said, some are kind of highlighted in the box. I'll mention two, and then I'll come to the panels. The first one I want to talk to particularly our community representatives about is the issue of the most marginalised falling between the gaps. And thinking about sort of equity and inclusion. We had a lot of conversations, didn't we, about equity and inclusion, and how our systems could be more responsive to different groups. So I'd love to hear your thoughts on that. The next question after that, so if you have a little think about that one, the next question after that is kind of to Jane and to Laura, is about I guess, when we started this process, we had a really good set of Viva standards, which are highly evidence-based and sound in terms of what they can achieve for HIV care. But a lot of our stakeholders talked about that variation, and have we got enough of a hook to kind of really make change happen? So my question to both of you is, how do you see this document and ICS's being a great opportunity to achieve that. So, you know, what's going to be, I guess, different about, you know, why is this a real moment for kind of making change happen? So I'll come back to our community leader voices, and I just want to talk to you about equity and inclusion, and kind of, you know, did you feel optimistic as we went through this process that actually there's a moment to kind of do more, and just some of your thoughts about, you know, what came through some of the community discussions on equity and inclusion?
I think I'll start. I think initially there was a sense that, you know, how much involvement we as the community, you know, felt. Are we really being included? Is everybody's voice being heard? Are the marginalized being included? You know, but as we sort of worked more and more together, I think there was a realization that this is actually a really good opportunity to be able to sort of, you know, fill those gaps where we feel that they're you know, that they're lacking, or that there are gaps. So for me, as someone from the community who was involved, and I'll pick, for example, from the Black and ethnic minority, from the Black African, you know, we did raise issues around that, and they were seen and they were addressed to. So it does feel like there is a real opportunity, and I think it would be really important and a shame if we didn't make use of that, but really important that we took this opportunity and sort of take it forward. I don't know if you've got anything to add, Mel.
I'm liking your optimism. I think from the very start, I was very kind of skeptical of the power of reports. I was involved in the King's Fund report 5 years ago, the future of HIV services. And so, you know, and I think when the community voiced, we don't want, you know, we're frustrated by saying, you know, these are the standards, these are the Beaver standards, you know, seamless pathways, person-centered, we can say that. But as you're saying, how are we pulling it in? So in a way, it's going to, you know, hopefully Jane and Laura, you know, the second question that you posed, that's the real point. And I think with this report, it was such a difficult time as well, because we just don't know what's going to happen. But I really kind of felt that we ran with this. If we don't ask, we're going to get nothing. So it's like, it's here, there is a suggestion, there is an opportunity, rather than just not having anything. So how can we stop people falling through the gaps? Is just to be asking, to be kind of proactive in that. We still don't know, and there's still potential for failure because there is lack of funds. But I think the fact that the community advisory group is quite a stronghold and can talk and is going to be maintained, which is great, thank you Fast Track Cities, that there is that opportunity to, as I said, keep our eyes open and to just see what's going on, and to be able to report back and to be accessible to have that feeding back if people are dropping through the gaps, because it is going to happen. It's such a fragmented system. It's a big ask to pull it together. But I think the idea that it's, you know, it's in the name, the integrated care system, the fact that there's the potential to integrate, I think, yeah, it could be optimistic.
Yeah, I always say when doing sort of transformational change work that actually, you know, sort of it feels in the middle of it that you are pushing against a resistance, and your energy, you have to keep that drive going, and we get that energy and drive from a lot of the things that you've shared with us as we've been going through this process. When you look back over 10 years and you see how far things have come, it's often a really inspiring picture. So change doesn't always happen as fast as we would like, but we keep pushing because we know that we will get there, and we've got real, I think, a sense of really strong ambition in this document. I'm going to ask Laura and Jane if you want to comment on that as well. It's sort of like, you know, why does this feel like such a key moment for pulling through some of those really inspiring Beaver standards in terms of what good care looks like, and developing an evolving HIV care report? So the timing and why now, and what's going to be different? Jane,
I'll kick off and I'll leave Laura with the Beaver standards, but I think there's a number of things. So I'm reminded by other work that's going on in London, the sort of framing of this, that there is not equity on outcome across London. Yes, of course, we've got, you know, fabulous overall results virologically, but they're not consistent. Not every area has got the same levels of virological suppression or testing. So there is something really important about the data. And we've got to be absolutely clear that the monitoring and the data is fit for this next stage. So, for example, you know, Valerie and her team at Public Health England have in the last week or two helped us put together some data at different levels across London and across each ICS, because one of the things that the ICS are asking us is, well, what's it like in our patch? Well, we've got to be able to answer that. So we have to be able to have the right data about what's going on to start us off. And then if an intervention is made, to know what's made that difference. I think the other thing that is at the moment really important is that, you know, those of us working in HIV have known about health inequalities forever, because it's always been the thing that has been so prominent in our working lives. But COVID has woken everybody else up to it as well. And so the whole issue of health equity is on everybody's lips. So we are ahead of the game, because we've been thinking about health equity for a lot longer than maybe some other people in the world. And so we have got data evidence to start to move some of this forward, and constructing the debate around whether people can reach our services rather than can we reach people. Can people take our treatments rather than can we give them our treatments? How do we put it that way round? And then having the data and the monitoring and getting those metrics right. So making sure we've got PROMs and PREMs and the positive voices data that Public Health England have been leading on, that is designed in a way that these new structures can make sense of. So that's where I would start from. Thank you.
Thanks, Jane. I mean, not much to add to that, really. I mean, the Beaver standards, I think one of the fantastic things about this report, and as Mel flagged at the beginning, is the Beaver national standards are the foundation for a lot of what we've based this on. And I think by embedding those standards into the plans, it helps validate them and it makes them the goals to which we must aspire. It's always been the challenge. I mean, ultimately, the other thing we have is our national service specification, which is an NHS England-led document. And ultimately, I think that's what care will be based on. But that also heavily references various bits of Beaver guidance, which is good. I want to say one thing that it doesn't mean to be pessimistic. I just want to be realistic. Is I completely agree with you, Jane, that we need data. But when we talk about on our patch, you know, let's take North Central London as an example. Many of the people who choose to get their care in North Central London aren't geographically or based on their residential address part of that North Central London patch. And despite hearing verbally that it won't matter and that people can continue to get their care everywhere, because I think it's hard to measure, but I have not found anybody who doesn't believe that the ability to get your care wherever you want is one of the reasons that we do enjoy such good success rates. And again, I don't want to say we're being perfect, we're not, but we do have much higher than average success rates for HIV care than similarly resourced countries. So I think that's something we really need to work out together. Now, in some ways, by providing equitable, confidential, patient-focused, peer-supported care in every region, actually people may eventually move towards seeking their care in their own local area. And actually, I think COVID has triggered that for some people, and experiencing their local service through necessity because of COVID has actually led many people to realise that their local service is perfectly good. So this may become less of an issue over time. But I think it's very difficult to embed freedom to get your care where you like in a place-based system, and that's again something we need to work through. And I don't mean it as a negative, but I just think it's one of those challenges as opposed to a barrier that we'll need to overcome.
I was just putting on myself on mute. So so the other question that's popped up in the chat box was about the primary care model, and actually it was interesting seeing participants sort of almost wading in and debating and answering themselves, which is always fantastic. But I guess a lot of the Evolving HIV Care focus is on you know, living well, longer term with HIV, and there's a key role there for primary care. So I guess, what do we think some of the kind of change challenges are going to be for primary care? You might have seen some of that conversation happening in the chat box. And from the sort of clinical network perspective, what are the kinds of challenges that you hear, Laura?
Sorry, Jem, I was looking at the chat box. Can you repeat that question?
So yeah, so a lot of the change in terms of living well, long-term condition management is really kind of resting with a kind of a primary care base.
Yeah.
And so if we're going to achieve that and develop some of the models that our communities have told us that they want to see, and some of the feedback they've given us on sort of the work with primary care, I guess, what do you think are going to be some of the challenges of the clinical network? Have any discussions on that?
Well, in terms of measures, sorry, because I was just looking at Philippa's comment about how HIV care measures are not the only ones needed here. No, of course they're not. But then we've really moved on. Actually, just prior to this meeting, Tristan was chairing a really interesting discussion, and one of our colleagues in South London has embedded patient-reported outcome measures and also patient activation measures into their routine care. And Philippa, good to hear from you in the chat if that's something that happens routinely in primary care. I think we do measure broader things. We measure satisfaction with services. I think positive voices, as Jane mentioned earlier, is a real testament to people's engagement in HIV services. But I guess this is where we need to learn from you. What are your routine markers in primary care? What markers are you using to monitor health and well-being outcomes, and what can we do to help you measure those and help apply them to our clinics as well, so that we can then cross-compare data and support each other to provide the best models.
Thanks, Laura. And actually, one of we've got a series of improvement projects within the Fast Track Cities work that are out there doing some really incredible work on how do we support quality of life improvement? How do we even measure it? What are the questions and ways of looking at quality of life for people living with HIV? And there's a huge amount of learning now coming out of those improvement projects about that sort of key aspect of the model in terms of improving health and well-being, which is fantastic. Okie dokie. So in terms of the other bits that we've probably not covered, I don't think very well, in terms of, one of the aspects we haven't conveyed very well, it would be worth us kind of picking up in the Q&A. It hasn't come into the chat box, but I think it's kind of, it's something we talked about a lot. So we talked about how through COVID, there's been a huge amount of learning about new models and ways of delivering services. And just thinking about sort of the ways we're working now, there's some downsides in terms of the way services are being delivered at the moment, and there are some upsides. And just sort of trying to sort of understand for people on the call, sort of like how did sort of doing this through COVID, how did shaping the Evolving HIV Care report through COVID, what were the things we thought about differently because of the ways that people are delivering care now? Pause there. So Jane, I don't know if you want to pick that one up.
Yeah. Well, I think there's a number of things, and again, Laura was deeply involved with this. But I think if we try and, without siloing it, just think, because I think the things that happened differently in different waves of the pandemic. So I think the first wave, we were all in sort of crisis mode. There was a lot of mutual aid. There's a lot of people coming together and networking. I think in the second wave, we'd learned about things like digital. We'd learned a bit better about how to do things online, but not perfect, but that was happening. And I think now we've got to a point where we're hitting a sort of wall of exhausted staff and people trying to work out how to take the next bit forward. So I think it's evolving. I don't think we can say what happened in COVID and it was like this. I think at each point something different is happening and the narrative is evolving. But the other thing that was happening was that whilst the clinical services, many of the doctors and nurses were being redeployed and clinics were closing their doors to face-to-face care, the voluntary sector was completely overwhelmed with more people because they weren't able to get support in other places. But at the same time, as I understand, and our voluntary sector colleagues have been, Kat and the team have given us very clear narrative about how those organizations were so critical. The food chain, seeing huge numbers more people coming in, so the wider determinants of health, people losing their jobs, people having difficulty with money, people with all those other things, impact on how they access their care. And of course that's going to have to be considered as we think about this bigger picture. But I think the one learning that I take away from it is, this kind of sense, it's all going to be fine online. Well, it isn't fine online if you don't have money for data, and if you don't have a room to have a private conversation. And an awful lot of people living with HIV in our city have neither of those things. And despite trying, really trying as best we could to find out how to make sure everybody could get access online, it doesn't happen. So this kind of idea that there's a brave new world and that so long as you're online, it's all going to be fine, is not universal. And it may improve inequalities in some areas, but it may build on inequalities. So we have to look very, very carefully at what works and keep that going, and what was an emergency and might need to be changed.
And there was a lot of discussion on that, and Rebecca's you're back on screen, aren't you? I don't know if you or Mel want to describe sort of what were people saying from the community voice perspective about what was happening during COVID.
I mean, I think Jane's covered that towards the end of thing. It's just reiterating what Mel's put in there, that yes, we there was lots of digital sort of stuff being implemented, lots of remote clinics, but also on the other hand, on the flip side, we'd seen an increase in mental health, sort of mental health issues on the increase, intimate partner violence, poverty, also the lack of privacy and confidentiality for people to be able to have those conversations. So yeah, it's just highlighting that, and in a sense agreeing with Jane that no, it is not universal, and we need to take all those things into consideration.
Great. I do remember that conversation about the impact of COVID, and in a way, this document is crucial in terms of time point, in terms of ICS development, and us being able to bring this sort of new systems into like upfront, being ready off the starting mark, and really in terms of capacity and capability delivering on HIV care. But also with COVID, we're going to be in recovery as well, and that sort of sense that actually we've learned a huge amount about digital care, the bad, the good, the opportunities for productivity, but the issues and impact on whether it's always the right model for all of the groups that we want to reach, and yeah, the impact on voluntary community services that Jane described. So
Gemma, can I just come back in? There's one last point I just wanted to make there, which is that Laura and David Asbo and Valerie have led, and I've been sort of around the edges of an amazing piece of work doing a survey of all the clinics across England, actually, but with a subsection in London as well, about what actually was happening. And Gabriella has just submitted that for publication. So there is some really quite nice data, and it was presented at Beaver, but actually we've got some quite robust data to go back to about, that was wave one. But Laura, you sort of led with Gabriella that piece of work, which may help inform us.
Great.
Sorry.
No, that's fine. That's great, Jane. So we're coming to the end of the Q&A session, but I think you've also not just experienced the document, you've experienced, I hope today, the vast stakeholder network that is coming together around it to try and ensure that there's momentum for delivering change, and we hope to continue that as we go forward in Fast Track Cities, and see this as very much a sort of a platform that is owned by all of us across the sector, as a way to deliver change together. So I won't say any more than that, and I will hand over back to our chair, Jane. I want to thank everyone for their questions as well. Thank you, people. Jane, over to you for closing remarks.
Great. Well, thank you, Gemma, and thank you very much for everybody who's taken part in this discussion. I'm only too well aware, having talked about the limitations of digital, in that nobody's had a chance to say anything apart from us lot, and we've been chatting away, and everybody else has had to make do with putting bits in the chat. So Gemma, thank you for trying to pull that together, but I'm aware that had we been in a room with a glass of wine, a lot more might have been said.
And ice cream.
And ice cream. So I hope we will have those opportunities. But I think what we really were hoping to get out of this evening was to go into a little bit more depth about the report, and really to encourage your feedback from everybody to please fill in the Survey Monkey, so that whatever the final draft looks like, it is as robust as it can possibly be, that it's got as much input from as many voices as we can possibly get. And also, you know, are there gaps? Are there things we haven't added? Are there things we haven't thought about? Quite apart from what's in there, what isn't in there? And I know it's long enough as it is already, but nonetheless, we'd be really keen. And although we've designed it very much with these ICS post-COVID things in mind, it seems to me we don't want to miss any particular audiences or stakeholders, because it's been a huge amount of work and we're not going to have the opportunity to necessarily do this again for a while. So are there other audiences now that we should be pivoting towards to make sure that we're broad enough and that we're speaking with enough power to the right places at this particular moment in our history? But I think you've heard, and I hope that this has been as inclusive as possible. I think one of the things that it has shown us is that there's not many places in our system where everybody can come together around one table, and this Fast Track Cities initiative, if nothing else, has at least allowed us to all sit down together. And I think the other thing it's shown us, and again I take I think the things that Mel and Rebecca said about being a model, you know, we're trying to share some budgets across boundaries. We're trying to help things get spent in different bits of the sector. So it may be a learning opportunity to how we might do some of this cross-cutting work. But for the moment, I think, thank you all very much for coming. Thank you all for the comments and the feedback. Please use the Survey Monkey. Thank you to everybody who's done all the work. And for the moment, and Gemma, I can't look at the chat and this at the same time. I don't know if there's anything else burning, but for the moment, I think, please engage with the Survey Monkey, however inhuman
you might
it is.
go away and have more questions, and we'd love to hear them.
Please put them in. Exactly. And I can see that Eleanor's put that in the chat so that we've all got that. But for the moment, I think I would say thank you all very, very much, and go and get an ice cream and some water and whatever it is that will get you through this evening.
Wonderful. Thank you, everybody. So we're going to close the webinar now and the recording. It's been lovely to spend this time with you, and thanks to our speakers. Thank you. Bye.
Thank you. Bye.